My topic, choosing cancer medicine wisely in Africa. So I'll start this. This is my introduction. I think we should always learn to go back to the basics. And if you Google choose, what does choose mean? Right. So choose is to pick something or someone which is the best or the most appropriate among two or more options or alternatives. So it means you have a choice. And then wise, because choose is a verb, and then wise is an adjective, right? It's an adjective. What does wise mean? So wise, if you look first for the synonyms, they'll say sensible or prudent, right? Those are some of the synonyms of wise. So it's having something or showing experience and knowledge and good judgment. So if you combine the two, is choosing the best or the most appropriate cancer drug, uh, putting your experience and knowledge and together with your judgment in place. This is the topic that I've been given. It's a mammoth task given by Dr. Jerry, but I'm glad and I accept it. So classically or standard, this is the way the choice is made through this evidence-based choices through guidelines. We have various guidelines. This is how you're supposed to make a choice. If you want to treat someone, which protocol should I use? Which drugs should I use? There should be evidence against whatever you want to apply, which means you have to have guidelines. We are fortunate as a country. We have a national cancer treatment guidelines. We also have the national standard treatment guidelines, STGs, and we have the WHO essential list of medicines. And looking now, if you now corner it or narrow down to a specialty, the most commonly used guidelines are the NCCN and the ESMO guidelines, right? Now, if you look at this, there's a lot of contradiction. And that is why the issue of choosing wisely comes about. If you look at the WHO essential list of medicines, it's under Section 8. So Section 8, Section 8.1, it will tell you immune modulators. 8.2, it will tell you cytotoxic drugs, whereby there's a list of around 35 cytotoxic drugs. But is it really true that we only have 35 cytotoxic drugs? When you look at the list of targeted therapy, which is Section 8.3, there are 10 types of targeted therapies that they've mentioned there. And I tell you, if you look through that, you'll not find bevacizumab, something that we commonly use, right? And this is the 22nd edition of this essential list, which was released in September 2021. So it means it's not something that was picked from the air, but through vigorous scientific review of literature and clinical trials that have brought up this list of drugs. Now, if you go to our National Cancer Treatment Guidelines, the range of drugs that we have there are so many vis-a-vis the standard treatment guideline. So classically here, what you'll see is a collision of politics versus science, which is classical, and you can never avoid it, right? If you want to survive, you need to accommodate. As a scientist, you need to accommodate politicians. And as politicians, they need to accommodate scientists, all right? So if you look at what us as experts of Tanzania proposed in our treatment guideline, the national guidelines, and if you look into the standard treatment guidelines, that it is issued by the Ministry of Health, you'll find that most of the drugs, the new molecules, are not there. And hence why I have this topic of choosing wisely. This is a preamble. I'm just trying to bring up to speed. Now, in our setting, instead of going for evidence-based, looking into patient safety profile and the drug profile, we look into the following. Is it available? First thing we ask ourselves, is it available? Rather than saying which level of evidence, is it category 1, category 2, we ask, is it available? The next question we ask, is it affordable? And that's why I've put the NHIF logo there. I hope there are no NHIF members here. All right. If you ask me, NHIF is one of the bottlenecks into cancer care in the country because it affects the second bullet. We are sometimes geared to make a choice of a drug or of a protocol just because these are the drugs that are approved by NHIF. Again, is it accessible? It might be available, it might be affordable, but unfortunately not accessible. And here accessibility is both geographical and also could also be in terms of competence. All right? And then administration. How feasible is it to administer this drug in your setting? I remember when we started hearing about immunotherapy, I think we were all scared about administering immunotherapy. Are we competent? Are we able to manage the acute or immediate side effects that will happen during the infusion? Are we capable of doing that? Do we have an ICU? Do we have a crash cart? If the patient goes into arrest, are we able to resuscitate this patient? These are all limiting factors which guide us on how we can choose our drugs. But in a setting where everything is ideal, you'll find that this is not a limiting factor. So in our setting, we use these parameters to make choices. I'd like to present a case on breast cancer. So I'll base now on the breast cancer, how we manage breast cancer and how we treat and what drugs we choose on breast cancer. If you look, and I will refer to NCCN guidelines, which I believe everyone here is more comfortable and conversant with. If you look for early stage breast cancer, the algorithm will say that if it's hormone receptor positive but HER2 negative and lymph node negative, or lymph node status is only N1, all right? And here again, we don't do sentinel lymph node dissection. So these are some challenges that we face locally. But the algorithm tells us we need to do OncoDX test, which is a 21 gene assay for breast cancer genes in an individual. Why? Because if you do oncotype DX and it's 25 or less, the score, you don't need to give adjuvant chemotherapy. You only need to give endocrine therapy. And if only is above 26 and above, that's when you consider giving adjuvant chemotherapy. But are we able to do the oncotype DX? Last time I checked, the cost in South Africa, not even here, not even in Nairobi, in South Africa was around $8,000 in South Africa. So I don't know in Kenya, I don't know if we bring it here, how much will it cost? But imagine if we were able to do that. That means we'll be able to, how many patients will be rescued and saved of not being given chemotherapy? At the same time, how much our institutions would have saved. Because imagine, most of our patients are on treatment for 4 to 6 months of chemotherapy. there's a lot of time lost because these people that were supposed to be working, they're now receiving treatment and the cost of medications. This is one example I wanted to share. Another one is when you come to early stage but HER2 positive, evidence supports use of trastuzumab as an adjuvant therapy, but we also know evidence also supports pertuzumab. And they say that if you use concurrently trastuzumab and pertuzumab, it has better outcome, it has better efficacy, right? And even the NCCN guideline, you'll see the one that I've circled there, they said the combination of trastuzumab and pertuzumab, to them is category 1 preferred, right? But realistically, are we able to afford to give both pertuzumab and trastuzumab to our patients? I believe the answer is not. Probably the only very few that are well off can benefit from all. And looking at the WHO essential list under targeted therapy, pertuzumab is not even there. All right? It's not part of the WHO essential list drugs. So it's a luxury to add pertuzumab. So we should be very careful while we are using these guidelines. We should always customize it into our setting. I wanted to give you this as an overview, but now when we go now to the cytotoxic drugs, if we look for HER2 negative early stage breast cancer, you can see the top row, they said preferred regimens. Those are the preferred regimens, right? Meaning that if you are in a setting where everything is available, there's no issue of affordability, availability, the 4 bullets that I've placed, then the first column should be your preferred regimen, right? Now, dose dense, it means every 2 weeks. And with dose dense protocol, you need to be giving fulgastrin as a supportive drug after immediate 24 hours after the chemo, pegfilgrastim, or 3 days after the chemo if you're giving fulgastrin for 3 days. Now, pegfilgrastim costs around $200. Now, by you changing the frequency of instead of making it every 3 weeks, making it every 2 weeks, you're adding an additional $400 to the cost of the patient. And is the pegfilgrastim available? Not in all settings. So we should be very careful while selecting these protocols and regimens. Again, you'll see that there's a weekly, and they say that the second bullet, they say preceded by weekly paclitaxel, and you see that there's an hyperscript of C. So if you go down and read about C, supporting that although if you give it 3 weekly and weekly, the efficacy is more or less the same, but they'll tell you they prefer the weekly one. Now imagine the weekly cost, because the weekly you give it at 80 milligrams per meter squared, vis-a-vis 175 milligram per meter squared that you give it every 3 weeks. So if you look the combined effect, in 3 weeks for the weekly one, you've given 240 milligrams per meter squared. So another extra 70 milligram per meter squared more of the drug you've given to a patient. But at the same time, looking at the indirect cost that this patient will incur to travel every week to your clinic for the chemotherapy, it's another added cost, making it sometimes not feasible for you to offer such therapy. So this is something that we should be looking at it very cautiously and not just adapt things from nowhere and then say that we think that we can do it. We have to make sure that all those 4 parameters that I've mentioned are met before you can adapt a protocol. This one is for the HER2 positive protocol. And for this one, I just wanted to show you, if you go to the second row, first column, neratinib, the use of neratinib, and also the use of TDM1. I've seen patients going abroad, coming back, saying that they were prescribed TDM1, and they want TDM1 to be offered here. But if you look, even NCCN, at least here they said, useful in certain circumstances. So we should not just be like parrots, speaking out or just assimilating everything that is pumped into us, but we should be very careful while selecting these drugs. The last thing that I also wanted to talk on breast cancer was the endocrine therapy. We all know the use of endocrine therapy. Classically, we give tamoxifen, right? Sorry, let me jump this. Yes, this one here. Classically, we give tamoxifen, but there was also emergence of aromatase inhibitors, letrozole, anastrozole, exemestane, right? It all depends which one you want to use. And we all know that for premenopausal, we prefer using tamoxifen, and postmenopausal, the preference now is to use aromatase inhibitors. But we've seen some oncologists prescribing an aromatase inhibitors in premenopausal women by inducing ovarian suppression, either surgically or pharmacologically. If you do it pharmacologically, it means you're giving, let's say, goserelin, Zoladex. Now, Zoladex is again another $150 to $200 drug on top of the aromatase inhibitor that you're going to give. And we all know tamoxifen and the aromatase inhibitors work more or less the same. It's only showed efficacy more, probably a little bit, in postmenopausal women. So why subject a young woman giving ovarian suppression, inducing early menopause in this patient, and then giving again a more expensive drug than tamoxifen, which is very relatively a cheap available drug. The use of biphosphatase, zoledronic acid, is relatively cheap, but there is new drugs like denosumab that is used also for bone mets setting. Where do you draw a line? Where do you say I should use zoledronic, where I should use denosumab? If you look at all literatures, they'll tell you zoledronic acid acts and the efficacy is more or less the same as denosumab, but with an additional cost of almost $100 more on a denosumab cost compared to zoledronic, and which requires, again, cold chain storage. So we should be very wise in making decisions or choosing cancer medicines. And I believe, as I close my talk, that having harmonized guidelines that are resource stratified, that means although we have a national guideline, although we have the NCCN guideline, it's important that you also develop guidelines within your institution, looking at your resources, looking at the 4 parameters that I've mentioned, to see that if you can accommodate certain drugs and prescribe it to your patients. Thank you so much.